Good morning, everybody. So in case you're wondering, this is the APP session. For some reason, our slide is not up there, but my name is Chris Singh, and I'm from Akron Children's. I'm an adult nurse practitioner. And this is Angela Oder. She's from Cincinnati, and we're the moderators for the session. So welcome, everybody. It's hard to believe that it's now Saturday. So much excitement coming up for NACFC. So it's always a little sad on that last day going home, but Seattle has been wonderful. So we're going to go ahead. Angela's going to introduce Christine for us.
Hi, everyone. Christina Mavaro is a family nurse practitioner at NYU Children's Hospital, and she earned her nursing degree from Wagner College and later her DMP. Please welcome Christine.
Good morning, everyone. I have no disclosures. So today I'm going to talk about a quality improvement initiative at NYU that we started in 2024. The name of it is the First Stretch Implementing Liver Elastography Screening in Patients with Cystic Fibrosis, a Quality Improvement Effort. So this is a little bit of the presentation overview. So we'll just talk a little bit about cystic fibrosis liver disease, screening guidelines for liver disease, new advances in therapy, and quality improvement initiative. So what are the different types of cystic fibrosis liver disease? So there are mild forms of CF liver disease. So we could start off with cholestasis. Some infants with CF develop cholestasis in the newborn period. This is where the CFTR mutation can cause the body to produce thicker bile, which slows the bile flow. The slower flow of bile can cause health problems over time, such as inflammation in the liver, fibrosis. However, cholestasis can improve as the child grows. Also, we have elevated liver enzymes. Elevated liver enzymes often indicate damage in the liver, but as we know, a lot of our CF patients have elevated liver enzymes a lot of times before symptoms of CF liver damage emerge. However, liver enzymes are common in children with CF, and they're caused by medications, Trikafta, infection, and malnutrition. However, they also can indicate more severe forms of liver disease. So your center, your doctor could help determine the causes of these elevated liver enzymes by monitoring the enzymes and doing further testing for causes of the liver disease, like abdominal sonogram. Fatty liver disease, this is when the extra fat in the liver sometimes can cause inflammation in the liver called hepatitis. Scientists don't know yet whether fatty liver disease in CF always leads to more forms of liver disease or whether it can be reversed. It can often affect children with malnutrition who are underweight, and as well as children with CF healthy or excessive weight. So here are more severe forms of liver disease, cirrhosis of the liver. Cirrhosis is permanent, advanced form of liver disease. Children with cirrhosis may not have symptoms in the beginning stages, and treatment depends on the cause. Sometimes there is no treatment to prevent the liver progression, which is in the case of CF liver disease. Children with cirrhosis, no matter the cause, might need a liver transplant. There are two types of cirrhosis that children with CF liver disease can experience. Focal biliary cirrhosis. This type of cirrhosis is found in small section of the liver, while most of the liver is normal and healthy. Usual focal biliary cirrhosis does not progress to the liver not functioning. And then there's multilobular cirrhosis. This is where damage in the liver is caused by growths that form. This type of liver disease can often progress to the point where the liver does not work well. Sometimes this leads to internal bleeding or collection of fluid in the abdomen. Children with complications of multilobular cirrhosis may need a liver transplant in the future. These are the screening recommendations for CF patients, annual hepatic labs, CBC, PT, INR, AST, ALT, total and direct bilirubin, ALP, and GGTP. So there is advanced imaging. There is elastography and MRCP. Elastography is it's an adjunct to sonogram, and where the abdominal sonogram looks at the structure of the liver, the elastography or FibroScan looks at the tissue of the lung, and it's an adjunct to abdominal sonogram. There's also biopsy. Disadvantage of biopsy: it's invasive, difficult to repeat. Technique may be underestimate severity of the liver disease, but elastography detects changes in liver stiffness, but it's it's more cost effective and less invasive. So these are the advanced imaging, some of the thresholds of CF liver involvement and threshold of active CF liver disease. So these are some of when we do elastography, it measures the stiffness, and these are some of the thresholds. So in our clinic, we started because, we're doing now modulator therapy younger and younger. So we developed a quality improvement initiative in our center, and the objectives were for liver diseases like well-known potential complication of CF occurring in 10 to 15% of individuals with CF and contributing to 2.5 to 5% of CF-related mortality. So hepatobiliary manifestations in CF can include those related to underlying CFTR defects, such as biliary cirrhosis, portal hypertension, secondary sclerosing cholangitis, nodular regenerative hyperplasia, cholestasis, and lithiasis. Those of the can cause hepatics can be caused by hepatic stenosis, drug hepatotoxicity, and those related to extra hepatic disease, such as hepatic congestion. The introduction of a highly effective modulator has transformed CF care and extended life expectancy. However, these therapies may have some liver side effects. We aim to enhance early identification of CF-related liver disease by improving standardized liver screening through referral for liver elastography from 0 to 60% by January 2026. So the project is still going on. So our QI team is made up of most of our team members. The goal is to improve processes surrounding diagnosis of CF liver disease after 2 years of life. So it involves support, education, standardization of a process, a flow, a timeline providing a structured roadmap for progress, enabling better organization and resource allocation, and timely completion of the project goals. Communication, so this project, you really had to communicate with all the team members, so CF team, liver team, patients, and families. Collect and analyze the data. Data collection and analysis lie at the heart of the quality improvement, and we developed a spread, a dashboard, and spread the successes or not. Sorry. So to start the project, we developed a process map to monitor and evaluate the effectiveness and the safety of the FibroScans. So we identified the patient and we did an assessment. We educated the patients and their families. The provider coordinates the appointment with the NYU liver team, and we're lucky to have a liver team right in our office down the hall. The patient has a FibroScan performed at the appointment with the liver team, so they'd come see us in the office and then followed by an appointment with the liver team. And then we'd send the patient for a 6-month follow-up and conduct follow-up assessments yearly thereafter if there are no problems. So the methods of the quality improvement project, our QI team identified the primary drivers contributing to the non-referral to hepatology or the liver for liver fibroscans, and developed an educational reference sheet for patients and families about CF liver disease. Because the biggest problem in our clinic is getting them to agree to do the fibroscan and staying in the office for longer. So we really tried to have them be seen the same day, so they wouldn't have missed appointments, because if we did a appointment later on for the liver team, they probably, some of our patients would not follow up. So patients scheduled for clinic visit were viewed in our weekly interdisciplinary meeting, and a dashboard was created to track the results of the fibroscans. Sorry. So, let me see, make sure that was a method. Okay. So the results in 2024, there were 31 patients over the age of 2 seen in the CF clinic, and 8 patients underwent fibroscans. 5 patients were male and 3 were female, and the average age was 11 years with the range 4 to 21. The 3 patients were taking modulators and 5 were not. There were no scans that detected CF lung disease. January to present, criteria CF patients ages 3 to 18 years old on modulator therapy. Total visits were from 3 to 18 years old, not 39 visits. Eligible to order fibroscans were 20 visits. Missed or ordered fibroscan were 14 if they were late or they missed their appointment. Ordered fibroscan at visit 6 and completed fibroscan were 5. Criteria for CF patients 2 to 18 years old not on modulator therapy. Total visits, CF patients ages 2 to 18 years old were not on modulator therapy, 17 visits. Eligible to order fibroscan were 7 visits. Missed ordered fibroscan at visits, 4 visits. And ordered fibroscan at visit was 3. Completed with 3. And some of these numbers were lower because our nurse that did the fibroscan in the office had left, and they had it was a process to hire a new one, so it was a couple of months before we got a new nurse. So the conclusions were, with a QI-based approach, we successfully identified a potential opportunity gap in screening for CF liver disease in our patient population throughout 2024, and have increased the percentage of fibroscans from 0 to 26%. So there's still work to be done. Hepatology referral and in-clinic fibroscan is effective for detection of CF liver disease in patients with CF, and further work is ongoing to the increased percentage of patients referred by 2026. So we did, after I decided to do this project, we still now, it's ongoing to 2026. We've seen, I think, 11 patients so far within a 6-month period have had a fibroscan. One patient has a fatty liver, but it's not from modulated therapy because we did it baseline before we started modulated therapy. But the patient proceeded to have a biopsy, and his liver enzymes have drastically come down. And we did go ahead and start modulated therapy, and the liver enzymes came down. So, but starting elastography is important because it's less costly. It's non-invasive. You can do it in young kids right in the office if you do have, if you have the availability, and it's an adjunct to sonograms. So, and it really could detect fatty liver. It could detect inflammation. It could detect. It looks at the elasticity of the liver and the stiffness. So you could really identify any problems. And it's a good test to do before you decide to go ahead and do a liver biopsy. Any questions? And and these are just some of the benefits. So we all know I just went over all the this stupid thing. All the benefits. It's timely coordination with the liver team, collaboration, standardization, identifying, of course, the patients at risk, patients on modulator therapy, early detection of liver disease. It's non-invasive to the alternative of liver biopsy, objective and accurate assessment, and it really can monitor disease progression or start of disease. And this is my team. Thank you.
Can you hear me? Okay. Just was wondering about how often are you meeting with your team, the liver team? And do you have any suggestions for how you went about establishing that relationship?
So we had an initial meeting with the liver team, so the whole team, my director, my co-director, and the CF team, we met with the liver team. We developed a process map, and we use Epic, so we Epic chat the nurse that works with the liver team when we have patients coming in, and we try to include them. We have to be better at it, just because time and everything. We try to meet with them once a month to see what we could do better, what we're doing, what's working, what's not working.
And then also you mentioned about patients, some reluctance to get the testing. And what do you hear from patients? I also have the same issue in our clinic.
So a lot of them, because it's young kids, they're frightened, when they come to the CF clinic. Just for a culture, they're frightened. So they think it's invasive, but we really have great child life where we work. So she's been instrumental in trying to, and the test is really fast. So, the only hardest part is sometimes you have to have them take a deep breath in, when they're going to ready to do, the scan. And that could be a potential problem. However, we have a great team there. The nurse is great that works with them. So.
Great. Yeah. Thanks so much.
Thank you.
Okay, I'm going to introduce our next presenters. They're doing this together. This is on the APP role document update. First is Abe Sender. Abe has been a PA since 2008. In 2010, he joined the CF team at the University of Vermont Medical Center, where he focused on clinical care and research in CF. Abe is also involved in the PEP enhancement program. The Partnership Enhancement Program. He's a facilitator. He's a consultant for the CF Pride study, and he's also a professional mentor for LEAP and the CF APP Fellowship Program. And then also Carly Tomczyk. She has worked with Pete's Pulmonary Team at Minnesota CF Center since 2008. In 2018, she became the Associate Director of Clinical Care for the program. She is active both locally and nationally in the CF Foundation. So welcome.
All right, good morning. So I'm Carly, and I'm going to get us started here. We don't have Abe has disclosures, I don't. So this is kind of just where we started. Last year, you guys may remember at one of our sessions, we introduced this idea of revising our role of the nurse practitioner and physician assistant in CF Care Center document. We had recognized that it had been 10 years since it was last revised, and as you all know, a lot has changed in CF care over that time. So we kicked that off with a survey last year at NACFC. And the aims of this project were really twofold. We wanted to update that document to reflect current practices with all the changes we had over the previous 10 years. And then the second aim was to try to create a comprehensive list of APPs, kind of a who's who, if you will, or Rolodex of people, APPs in CF care, so that we could network and we could know who each other are, where we are, what we're doing. Unfortunately, we were not able to achieve that aim. It became challenging for a number of reasons, mostly just the logistics of where something like that would be housed. Which brings me to how we best track our APPs now. So one of the ways that we were able to get the survey out to people was by using the database that's on the APP list, my.cff.org, and then also those who have signed up for the APP listserv. This is where we sent out our survey information to gather feedback from people. So this is a plug just to make sure that you are identified correctly within your center as an APP. Regardless of what role you play, if you are an APP, I know you probably wear many hats. You may be a program coordinator, you may be in research, but make sure you're also identified as an APP so that we can really capture who we are, how many of us there are as our workforce grows. All right, so this is what we did. This was the how process. We sent out the survey, we solicited for feedback from everybody, and then next we reviewed that feedback. We formed a working group. I think a few of you are probably in the room that were on that working group to help us just kind of delve through all of the feedback we got from people so that we can make the right changes and updates to the document. We also decided that putting links to the PA and NP state practice associations was going to be the best way to keep that information up to date. And we have this document done. There will be a link a little bit later on or a QR code rather in this presentation where you can scan. It'll bring you to my.cff.org so that you can take a look at the new and updated document. Our communication and share out plan is twofold happening right now, as well as for people to follow up with and see later on and read. We plan to share this with program center directors and send it out on listservs as well. We have not gotten to that part yet. So our survey details. So we collected survey information, like I said earlier, based on the database. We sent it out on email. The QR code was provided at NACFC last year. And we had the survey open for about 6.5 weeks following NACFC, where we gathered information. We got 103 total responses, and of that 60 were responding to Section 3, which was really what we were looking for, the changes and better understanding of what APPs are doing in their centers. So this is just kind of an update of how many of us there are from the last few years. So you can kind of put that 103 responses into perspective. You can see as of September 15th of this year, we're almost 300 in APPs in CF Care. So that's awesome. And growing every year. So when we got the data back, this is just kind of some of the highlights I'm going to share. 75% of our respondents indicated that they had held a leadership role within their center. Hold on. The notes don't show up on here, so I have to do them on paper. Okay, so this one is who's who at their center. So majority of people are nurse practitioners, followed closely by coordinators, and then you can see the numbers of advanced practice nurses, physician assistants called out on this as well. All right, this is the next one. So 75% of respondents did indicate that they had a leadership role within their center, and this is kind of the distribution of what that leadership role entails. You can see that other is kind of categorized as the highest percent, and that includes people identifying that they were leaders of their newborn screening program or their transition program, perhaps mentoring programs at their institution, all kind of encompass this other, and then QI was the next piece that kind of followed that. And then in addition to leadership within their CF Care centers, APPs are also leading at the regional and national level. And this kind of just talks a little bit more about that. You can see many APPs have participated in NACFC, whether through a presentation or a poster, the LEAP program, mentoring, community participation. Within their local chapters, kind of falls into that other category. There are a few that have not yet participated, but we hope to get those folks in somehow, and starting with roundtables is a great way. Give us your feedback, because we can always tap you to participate in the program for coming years. And then this one just kind of talks about the barriers to functioning at the top of your scope, because I think as APPs, as I mentioned earlier, we wear many hats, and functioning to the top of your scope, there are many barriers. And interestingly, 12% identified that they're not able to participate or practice, at the top of their scope of practice. And this is kind of that distribution of why those 12% weren't able to practice. And the biggest percentage on this was limitations related to their CF team. So that kind of will trickle into what Abe's going to be talking about next as to how we're going to address that so that we can help APPs better get to the top of their scope of practice. So I'm going to hand it over to Abe here.
Thanks, Carly. So Carly kind of ran us through how this project went, and I think we could do like a presentation on like the barriers to getting this to go off this morning, because we don't have our notes, and I had a brilliant idea of a third-party application that we're going to see if it works. And then I also didn't realize that I only have room for respondents for 50 people. So I'm going to ask everyone to have their phones handy because we're going to have some interactive stuff. And while we love everyone, I'm hoping that if you're an APP, you will do the mentee things if we can get them going. Okay. So why do I have a cake up here? So it was just APP week, and at my institution, I'm the chair of our APP council, and with our director, we ordered this big cake and had like a little event, which was lovely. And she had taken the letters of the sort of 6 APP professions, PA, APRN, CNM, AA, et cetera, and asked the cake people just to spread them around the cake. And I just feel like it's a great analogy of people understanding what we do. Just alphabet soup. Everyone can scan this if you're interested. This is the updated document. You will have to log in through my.cff, so don't do that now, but you'll have it up on your browser and you can do that later. Okay. Cool. So, all right. So what did we do when we updated the document? We appreciate everyone who did complete the survey. And for those of you who started and decided this survey was bananas, I totally understand. We needed a format redesign. The paper was full of awesome information, but also really kind of was not linear with what we do now. So we reformatted it. We updated clinical care, which has changed dramatically in the last 10 years. And we added a lot of this leadership and other programmatic roles that Carly was speaking of. So one interesting point we wanted to make and certainly add was that, as we learned last year, APPs are now eligible to serve as the associate center director in affiliate programs only. There is an established process for this. When I started making these slides, there were 2, and now there are currently 3 folks serving in this role. And Cindy called them out at the session yesterday. So thanks for doing that for all of you. I think that's a really great way to trailblaze. Okay, Menti. So now we have to switch. If everyone could get out their phones and go to menti.com and type in that code that I can't see.
37469427.
This one was just to get the kinks out. Are we having fun?
37469427.
Okay, sweet, this works. Awesome. Okay, can we have the next slide? Which says, so in your opinion, should APPs serve in the program coordinator role? I'm just going to give you a little minute on each of these. Awesome. Okay. And this, I think it'll keep going, but next slide, if you would. And so you personally, would you be interested in APPs formally serving in associate program director role, principal investigator in research, QI team lead, clinical program lead? Yeah, this one's on a scale of disagree to agree. Awesome. And then back to the slideshow. Thank you. Okay. So we've talked about the LEAP Fellowship Program, but this is another way that APPs have been serving in non-clinical leadership roles. Just briefly, it's a 24-month program. There's been 2 cohorts. The second cohort just finished. I'm pointing at Danielle. Just graduated this at NACFC. And it's been a 2-year program with 4 courses: Foundations in CF Care, CF Care through the Lifespan, Advanced Topics in CF, and QI and Leadership. And it really is sort of this like asynchronous program with classroom model and at home sort of clinical support with home mentors. So it's been a really interesting way to bring us together across the country without being in a single site. LEAP is being redesigned for a lot of reasons. We want to expand the access to more APPs. So it has been currently accessible only to folks in the first 3 years of practice. We want to identify the most efficient way to use fellows' protected time and optimize resources that are appropriate to that point in the APP's career. We had some feedback that some of the QI and leadership stuff was sort of overwhelming while trying to drink from that fire hose of learning all of CF in your first 3 years. So took an opportunity to kind of separate it out and create some opportunity for mid to later career APPs. So now the LEAP umbrella is going to look like there's going to be LEAP ACE Advanced Clinical Education, and this is going to be for folks new to practice in the first 36 months, and it's going to be a condensed version of the prior program that had been established and basically focus on clinical care and getting folks from that sort of novice to independent provider. And then there's also going to be some QI programming that's available for APPs later in career. That won't have any funding support, but it will be a nice it'll be a nice course for folks to take together with a cohort of APPs and learn together and kind of go through some of the moans and groans of not only QI work, but also kind of running your team as somebody in the APP role. I think that will be really helpful. And then we are trying to work on creating Leap Forward, which is kind of an array, currently a bit of an amoeba of ideas, if you will, of professional advancement opportunities. And we're hoping you all can help us gain some insight into where we should go with that. This is a QR code for the LEAP QI. If folks are interested, please scan this. It's going to be limited to 20 participants, and it's going to be January 26th through July 26th, I believe. Full disclosure, this is not my slide, but I'll leave it up for folks to get that QR code. So this was initially just sort of my note slide, and then as I was thinking through it, we felt like this is worth kind of sharing with you all. So as we're thinking about this leap forward, where do we go from here? Like, what would be accessible? What could we commit to and actually accomplish? Maybe brown bag lunches where we meet on Zoom. What frequency? What timing? What would be the content? Should we do case presentations? Should we talk QI? Should we talk scholarship resources, grant resources, policy change? Are folks interested in an APP research group where we share our projects and kind of work together to edit our work? Scholarly publication support. Are we interested in more award or recognition to kind of amplify our profession? Is there something, would we be interested in something APP specific? Do we want to suggest APPs could be eligible for awards historically held by reserved for physicians? Do we want to consider increased APP content at NACFC, which, by the way, there's been a ton more APP content at NACFC. Careful what you wish for. It's been awesome, and I've missed everything else. Back to Menti. Thank you. Okay, next one. Oh, did people already? Okay, cool. Oh, great. Look at that. See, you live, you learn. So this one is strategies for professional advancement. So things people are interested in. Awesome. Next slide. This one is what activities would you participate in? I see no one wants to participate in any activity. That's what we were afraid of. Awesome. Next one. So what ideas do you have to support APP advancement? So this one you can kind of write in short phrases. And I believe people can vote on other people's. I'm not sure. We'll see. Recognition. Good. I can't read them. Strong regional discussions. This saves, so we're gonna do something with this data that I can't see. I apologize. Remove barriers to promotion. Case discussions and clinical questions. Feedback. Love that. Connecting regionally. Awesome. And folks can continue to put stuff in there, please. And if we could do the last one. This one is whoops. Oh, I'm not sure. Did we go to the next one? Well, we can skip that one. It was a word cloud. Oh yeah, here. What aspirations for APP advancement and CF care do you have? These are like single words. Nice. Awesome. Well, you all can see this better than I, and as you keep putting them in, we'll get a bigger word cloud that we will put somewhere. Maybe we'll send it out on the listserv, or maybe we'll show it next year. So back to the... All right, so that's that. So any questions? A big thank you to all the members of the working group, Cindy George, Lauren Katz, our hosts for today, our chairs. And then, yeah, if there are any questions, we would be happy to take them.
I don't have a question. Paula Lomas, I do have kudos to you. Very good. Yes, about time that you updated that APP document, and thank you for doing it. It's a lot of work. Cindy will always be your number one go-to at the CFF, but I just wanted to make sure that you and everybody else in the room know that you don't need to create a rolling directory or whatever. If you want to pull, there is a way to do that on my.cff. Go to the people tile on my.cff, and on the left side, it has filters. Click on
This is great.
CF Care Center, CFF accredited, and then open up the tab that says roles. You can then click the nurse practitioner and the physician assistant, and then you can export that data and the contact information. Okay, so that's there. So don't
Reinvent the wheel.
Right. And as you said, it's only as good as the data that's put in.
Yep.
So all of you in the room, make sure that your program coordinator or director keeps that updated. So that will help. Then the second thing is, would love to be able to help you in spreading this information. So let's connect afterwards, because this is good work. It's hard work, and we want to make sure that we share it broadly. The listservs are opt-in. The emails you get from me are not. So,
Great point.
right. So we'll connect.
Thank you, Paula. Can we just see that word cloud one more time? I'm sorry. I just want to see it. Katie, will you take a picture? I just want to say.
So I am a former LEAP graduate.
Yes,
which
you
was
are.
which was an amazing program. Absolutely. And I've learned so much. Is there any thought about recording these sessions for future and then sharing them with people who were not part of that cohort?
That's a great question. As you may know, LEAP is in transition. The number one champion in heart and soul and knowledge and brain and nervous system of LEAP is sitting in the room right now. Cindy Brady, do you have an answer to that? She was asking about whether or not LEAP sessions, you're talking about the synchronous sessions.
Yes.
Obviously, great. Because we have the list of all the didactic stuff. If the synchronous sessions ever would be recorded or become available to other APPs.
They are all recorded, all 4 years. They're in a archive and ready to be handed off to the future. Part of it is, we really try to keep it fresh. So the curriculum requires constant updating, because if you haven't noticed, a lot has changed in CF in the last 5 years. So, that's a real challenge. But yes, I think the core of the success of the program has been these synchronous sessions. So it's been the independent learning, online didactic stuff that you'd usually sit and be lectured at. And then once you've completed that content, we would all come together and 2 or 3 fellows would present a case based on the topic. And we'd bring in a content expert. And, these IU courses, there's a lot of experts listed. So, and I think also having the strong clinical network enables you to tap your relationships with these experts and have them come in and talk. So that whole model, I think they're all recorded and they do exist, but keeping it fresh is a consideration. Thank you.
Yeah, and Angela, I will say one thing that happened between LEAP cohort 1 and 2 is like a lot of some of the didactic stuff got condensed into a lot of the IU courses. Not entirely, that was not the total of it, but those courses, for anyone who needs a refresher on anything, they're awesome. They're updated, I think, thank you, 2 years.
Hi, great talk. I'm Jeff Gold from OHSU. So two quick questions. One, I'm not an APP, so I don't know about the leadership infrastructure within the CFF for the APP group. But one is, I would just sort of say, is how well integrated are you in the other career development granting opportunities? For example, Digest does not allow for APPs in those grants, and I think that's a huge missed opportunity. And then the second question, sorry if I'm...
No.
And then
we concur.
Okay. And I think the foundation has to get aligned with this. You can't sort of say APPs have a strong role, but then say, but only certain grants are eligible to them. The second thing is that especially in the adult side of things, the need for PCPs is huge. And I'm wondering about whether there's been a LEAP Light program where it's not about training people to be primary CF providers, but rather training PCPs to be part of the CF care team. And I'm not sure if LEAP Light is the right term, but, something a little less intense than all those years, but allowing them to be effective care team extenders and be part of that team in that PCP role, which I think is going to be a huge need for our community and would actually vault APPs into a massive leadership role because they're filling a void.
Yeah. So thank you. Great points. I will say, and again, Cindy, help me here this talk sort of spanned out of rewriting the APP role doc. We also sort of really rewrote LEAP. And there were lots of different ideas that came in. And I was not involved in the folks who run LEAP tried to take those ideas and come up with the best solutions we could with the resources that we have. And I know that one of those ideas was trying to get primary care APPs embedded into CF centers. I know it felt more appropriate in the adult world a little bit, and what that might look like. And I think that idea kind of was spurred largely out of at last year's APP grand rounds when Whitney Brown came and spoke, and she presented some pretty incredible, I was very surprised, statistics on how the percentage of primary care that is delivered by APPs across our country. So it's I agree.
I concur. That discussion's been alive and not insignificant proportion of our LEAP graduates come from primary care, are trained in primary care. So that seems like they've already had a natural progression or fit to that potential role. But I think they need a seat at the table to continue this, because I think you're right. They are a natural solution to fill this growing gap. So
Yeah.
I'll leave it there.
And
They need a seat at the table.
I did see in the plenary yesterday, there was a slide that listed out all the different programs like PACE, Envision, Digest, LEAP. And then there was one that was primary care that I took note of and said, I have no idea what that is. It's new and I'm very curious. My suspicion is it's for physicians.
No, I think that one has APP. It's more about innovative programs to build primary care networks.
Got it.
That could sort of be, there was, I think, 4 sites.
It was the RFA.
There was 4 sites that got in. They can each get their own thing and do how they want.
Thank you.
Thanks. No, you're fine. Thanks. Thank you. Okay, so I'm gonna choose. Okay, so we're moving on then to Zubin Bakhta. Zubin is a pulmonary clinical pharmacist at the University of Utah, where he has worked since completing his residency in 2011. He provides both acute and ambulatory care for patients with chronic lung disease. He's originally from Texas. So thank you so much. He's going to talk to us today about GLP-1s and CF.
Hot topic, right? Everybody wants to know about GLPs. Changing track a little bit, we're going to be talking about medications. I've got nothing to disclose regarding this presentation. And part of our outline, we're going to identify the current treatment guidelines for CFRD. It's important because in order to get these medications approved, I think a lot of our patients need this diagnosis. If you don't have this diagnosis, it might be difficult to try to get these medications actually approved for patients. We're going to review the mechanism of action of GLP-1 receptor agonists and the relevant pathophysiology, as well as some literature regarding the use with people with CF. We'll also discuss treatments and potential side effects and interactions, because these drugs actually might not be the best choice necessarily for patients with cystic fibrosis, knowing the underlying disease process. Sorry. So CFRD guidelines. CFRD, cystic fibrosis related diabetes, affects around 20% of adolescents and about 40 to 50% of adults. It's caused by insulin insufficiency as well as fluctuating levels of insulin resistance. As we know historically, this can cause a negative impact on pulmonary health. So, I'm going to ask an informal poll. How long have people in this room been working with cystic fibrosis? How many people have been working in the last two years or so? Just raise your hand. How many people have been working from 5 to 10 years? How many people have been working greater than 10 years? Okay. So this is the big telltale sign, right? Like a lot of us have been practicing for such a long time frame that the big effect of modulators wasn't a thing, right? Like we were taught dogma one way. Like we needed to treat cystic fibrosis related diabetes one way. It was insulin, 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 right? Like when we've been doing that for a very long time frame. Modulators kind of changed that. Our patient population shifted. So whenever you look at the guidelines were published in 2010. So there greatly needs to be an update to the cystic fibrosis related diabetes guidelines. And you can go through, I've got the slides here about how to diagnose somebody with cystic fibrosis related diabetes. So then now what happened? We basically developed a new medication that kind of helped. The highly effective modulator therapy basically changed the game, right? Our patients used to be rail thin, usually. They were not able to maintain calories. They were not able to maintain body weight, and body weight was equated to health. The more you weighed, the better you would do from a pulmonary standpoint. So here's a mechanism of action in pathophysiology. It's not fully elucidated, but cystic fibrosis basically causes a mutation. You can lead to pancreatic insufficiency. You can cause inflammation that can occur, as well as beta cell dysfunction, which occurs in your pancreas. So this can lead to reduced glucagon levels, as well as glucose intolerance. So thinking about how to fix this problem, different medications can be utilized. So in a normal patient or a normal person, what we do is we will intake food. And when we take in food, we have proteins, lipids, electrolytes, carbohydrates. And what that actually does is it causes your body to release a glucagon-like peptide. Glucagon-like peptides in our bodies are released all the time, right? Whenever we eat, this happens. The point is, it's a very short half-life. So whenever we eat food, this molecule is released in our body. It happens, it's done, and then it's gone. So what has happened over time is people are like, well, what if I can make this a longer acting version? What if I can make myself feel like I'm full longer than just when I ate? So that happened. So GLP-1s. So what do they actually do? This is actually, I think, the key point or the take home of today's talk, in my opinion. What they do is basically they do a lot of different things. They're going to cause your brain to think that you are full. You take the medication, you don't necessarily need to eat anymore because your body is thinking it is satiated. Your heart, there's cardioprotection, there's increased cardiac function that can occur. Your liver actually stops. You're telling your liver, hey, we don't need to make any more glucose. Let's just chill for a little bit. And so your body is like basically going into like a homeostasis type of a standpoint. Your muscle is taking in more glucose and it's helping with the storage, and your pancreas is actually doing a lot of things. So here it's actually increasing like insulin secretion, glucagon. It's decreasing the secretion. It's increasing insulin biosynthesis as well as beta cell proliferation. So this is actually like hardcore working on your pancreas to be like, let's amp up what your functions are actually doing. The other thing that it's doing with your stomach is it's actually decreasing gastric emptying. Now, let's talk about cystic fibrosis overall. We know that DOS is a thing that we need to be worried about with our cystic fibrosis patients. So this is something that might not be the best thing if we want to like decrease gastric emptying, but that's how these medications work. So that's something we definitely need to keep into consideration whenever we think about them. So the incretin pathway in CF, it impairs nutrition, leads to reduced secretions of incretins. CF patients have been found to have lower levels compared to healthy controls, more specifically in patients that actually have cystic fibrosis related diabetes, which makes sense because you would think that the pancreas has lost its function from its overall utility. Optimizing pancreatic enzyme dosing can sometimes help. So that was the original push, right? Everybody was trying to get everybody on PERT, or highly effective pancreatic enzyme replacement therapy. And so if you did that, then you might be able to help the patient overall. But then GLPs may actually help improve glucose-dependent beta cell insulin secretion in people with CF. So this was actually something new, be like, hey, could this medication class actually be helpful to our cystic fibrosis patients? We can see this from modulator impact in people with CF. So ivacaftor, actually, whenever we had the first modulator, 12.1% rate of cystic fibrosis related diabetes compared to 18.3 not on therapy. So you can already see that the modulators were causing us to have less utilization of cystic fibrosis related diabetes, and mechanistically that made sense. But then we came out with more highly effective modulator therapy, right? So we can decrease inflammation, we can augment pancreatic beta cell function, and what these medications did was we basically were increasing weight in our patients. So GLP-1 medications, right? They're all the news right now. Everyone's talking about weight loss, about how we can utilize these medications for the numerous patients, not necessarily just patients with cystic fibrosis, but it takes a village, right? In order to actually get these medications initialized in a patient, you need to have multitude of people on your team. As we are talking about in this session, we've talked about multiple people being involved. We at the University of Utah actually have an endocrinologist that is part of our team. They may not always be available, but I think that they're a highly utilizable resource that you should seek out if you can. A pulmonologist, obviously. Our dietitians are immense. The dietitians that work with our group are so important because they help with diagnosis. They help with OGTT, like how often we need to make sure that they're being like screened, as well as nutrition in general. So many of us have been working with cystic fibrosis for over 10 years, right? So what we told patients historically was always eat as much as you can. Don't care about the calories, drink as much soda as you can, eat your gummy candies, eat as much as you can, right? And that has changed. We can't recommend that anymore, right? It was the status quo, and now it no longer is the status quo. So now we need to talk about healthy caloric intake, about what we need to do. So the original treatment was always insulin, right? Insulin was the only recommended treatment, still in the guidelines. It is still the only recommended treatment. However, we've got these new medications, the GLP-1 drugs that are out there. They might actually help us reduce the amount of insulin that our patients actually need. And some may not need insulin altogether if they're able to be put on the appropriate therapy. Oral therapies have been found not to be as effective. We don't necessarily recommend any of the agents that we do for regular diabetes, but we do talk to our patients about maintaining caloric intake and regular exercise. Like I mentioned, we do need updates to our guidelines. Whenever you look at the CFRD guidelines, these are the medications that are going to be recommended based on them. This, again, I will highlight needs an update because these are outdated now, right? 2010, come on, guys. So I think this will probably happen pretty soon. Ongoing monitoring continues to happen. We want to maintain an A1C less than 7. We want to maintain blood pressure, annual lipid panels, and we want to make sure that microvascular disease is not occurring in our patients. The barriers, like I mentioned before, this was all before highly effective modulator therapy. The game changed, and we need to change as a result. We're seeing additional complications, hypertension, cholesterol is going up in our patient population, and obesity is being now identified. What? Like, we didn't have that before, right? And for many of us, if you've been practicing more than 10 years, obesity, what? That wasn't a thing. So nutrition is huge. High fat, high calorie has been required for maintenance of pulmonary function. That was what we were told. We needed patients to be able to take as many calories as possible. And the consequences were poor diet quality, lack of nutrient, dense food, increased incidence in disordered body image, eating disorders, overweight, obesity. I know that whenever I started in CF, we had patients that would purposefully not take insulin because they wanted to remain thin. And now it's like changed, right? Like people are definitely a lot larger than they used to be, and they don't know how to handle that. So BMI is not the end all and be all. Individual care with a multidisciplinary team is very important. I think that this is where dietitians are huge. This is where endocrinologists can be very helpful. I think that we need to re-image the image of cystic fibrosis. Eating behaviors are important. I think utilizing weight neutral approaches are important. And we also need to be able to evaluate food insecurities. Historically, people have just taken whatever they were able to get, and they were eating, taking in whatever they were able to find. But it's changing. Our dynamics are now different. We need to caution how a clinician approaches counseling a patient with cystic fibrosis and their diet. It's no longer eat as much as you can, eat whatever you can, eat anything. Now it's more like, let's try to make smarter choices. And I think that that's where the team definitely plays a role. General population considerations. Overall, we've got weight loss strategies that have been around for a long time in the general population, right? So usually with a BMI greater than 30 or greater than 27 in some patient populations, we start thinking about what should we do to try to reduce our overall weight. So historically, the FDA has approved these medications, phentermine, orlistat. There's been a combination of things, but these were not studied in the cystic fibrosis population. So these helped moderately, right? Like 5%, 9%, maybe you can get up to like 10 to 14%. But then as you get lower on this list, you'll see drugs like liraglutide, semaglutide, tirzepatide. These are our GLP medications. They were also indicated and they've been studied in the general population for weight loss, and they've actually seen significant amounts of weight loss. So we know how to treat cystic fibrosis related diabetes, right? We were taught insulin. That's what we do. We know how to treat type 1 diabetes, usually insulin, right? Insulin. Type 2, we've got oral agents, we've got insulin, we can do that. And we have guidelines for type 2 diabetes now with obesity. We actually can help patients. Like we will give them metformin, we'll give them these other agents that can be utilized. But the question begs, what do we do with cystic fibrosis related diabetes and obesity in the essence of having highly effective modulator therapy and our patients changing their body habitus? So we know CF patients, they have low levels of GLP. We have highly effective modulator therapy, and they're basically increasing their BMI. So what are the GLP options? So I'm going to try to refrain from using the brand names of most of these medications, but we'll start with semaglutide. Semaglutide has been approved for type 2 diabetes, and it does actually have a pediatric indication from 12 years and older. And there is an oral formulation as well as a sub-Q formulation. However, I'm going to say this as my own personal bias. I think the sub-Q formulations for our cystic fibrosis population is a better route than the oral. So if you look at the oral formulation, I think that the absorption is poor. It's not that well tolerated even in the general population. So I think from a CF standpoint, I would refer or recommend a sub-Q formulation. So we've got these. The side effects are actually kind of big, right? Constipation, diarrhea, stomach pain, upset stomach. These are the big ones. Because you're slowing down the GI tract, I think that's what we really need to take home on these medications. Our cystic fibrosis patients are already predisposed for DOs, right? Like we've got that as something that we need to be thinking about. What these drugs are doing is, in effect, enacting DOs. We're decreasing gastric transit time. So semaglutide in people with CF, there was a 21-year-old male that was diagnosed, had an A1C of 10.4 upon clinic visit, and they actually, according to this case report, they started a GLP-1 medication in him, and after 3 months, his A1C went down to a 6.8, and he didn't need postprandial insulin anymore. This is like telling, right? Like, this is great. Like, it was really beneficial for this patient. And in specific scenarios, you can utilize these medications to help them increase their insulin production that the patient's already doing, and it actually can help them overall from a quality of life standpoint. The patient lost roughly 4 pounds in 6 months of taking the medication, and they were able to reduce their overall insulin intake. Tirzepatide, another medication that falls into this category. This one's great. It can be taken weekly, so it's less dosed, not necessarily from a day-to-day standpoint. What is interesting about this medication, actually, and I don't know how many people take care of adult patients or patients that might actually have obstructive sleep apnea. This just got a FDA approval for OSA as well. So Mounjaro, sorry, I was trying not to use brand names, but it just got an FDA approval for OSA as well. So that actually helps. So if you're able to reduce the amount of weight that a patient has, you might be able to improve their symptoms. Same side effects though, right? You're reducing gastric transit time. Another medication in this class, liraglutide, would also be included. It actually does have some pediatric data as well. So if you are taking care of pediatric patients, this could be beneficial. You do have to take this one daily. So that one is kind of annoying from that perspective. You can't just do a once weekly type of a medication. But again, the amount of insulin is reduced by utilizing this medication, even in people with CF. Exenatide was the first one that actually came out in this class of medications. If you go back to the history, it was made from like the Gila monster. Like that's where they actual found the molecule that came from this, and they were able to utilize it. It didn't really catch on a lot, but now definitely with the new onset of the newer medications it has. It was actually studied with 6 people, and they were actually able to see that you were able to lower the blood sugar, you were able to increase, it delayed the gastric emptying, but you were also able to decrease the GLP-1 and GIP were also lower in these patients with exenatide use. The bad side effects, mental health, I think is a big one to always like highlight. Weight has been a struggle, especially if you have adult patients. Patients used to be very skinny, and that was a part of their persona, right? With the modulators, that changed. So I think having adequate social work help, being adequate just communication with your patients is huge. I think that we're seeing more and more mental health side effects that are occurring because of modulators that we don't necessarily think about. Pancreatitis is huge. Rates have been comparable to placebo in the SUSTAIN 6 trial. Causality has not been exactly established. A lot of our patients, we think that their pancreas is kind of like given up. It's given out because of the disease, but we see that obviously it's still working because the beta cells are still releasing insulin, right? So there's ongoing studies, semaglutide in CFRD. There's an open label study to evaluate GLP-1s as add-on therapy to insulin for weight and obesity in patients with CF. It's supposed to be completed later on in this year. Dulaglutide is also being studied in cystic fibrosis related diabetes. The trial is supposed to finish in 2027, hopefully. And then we're trying to figure out where the actual role of these medications is. So I would be remiss if I can't talk about fake news. The GLP-1s have been huge, right? People have talked about them, and people have been wanting to gain access, but insurance won't pay for them for all patients. So what do people do? They've been going online. They try to find a place that can compound said products, and that has caused multiple hospitalizations and bad effects that have occurred. So it is very important that we try to stick with actual FDA approved products. Multiple bad effects have occurred. Up to 442 cases have been reported. That number should be larger now, based on compounded GLP medications. So I definitely would say, if you can try, get your patient diagnosed with CFRD, and then make sure that you are not trying to get them illegal compounds necessarily from a compounded place outpatient. I'm going to thank Dr. Holly-Ann Jacobs, who helped with a lot of this presentation. And at this point, any questions or comments?
Thank you, Zubin, for this very enlightening, eloquent presentation. I think this just is a great example of how we can use our resources in our community, because, you know, the guidelines, even the IU courses, are going to lag behind the evolving evidence. So in the meantime, we have resources like this right here. You know, we used to recommend the American Heart Association death diet and CF, and a lot has changed, you know. That was the joke we used to use. But I would just say these Indiana University courses, I can't recommend them enough. Interestingly, you know, the GI course has aged out and it's down right now, but I think they ought to talk to you about where the next course goes, but don't reinvent the wheel. Use your resources around you. And these courses have come a long way in the last 5 years. So thank you so much. But I think all of us would be missing something if we didn't tap into your expertise. So thanks.
Thank you for the comments. I also wanted to point out what we do at the University of Utah. So this is kind of our protocol of how we start GLPs for our patients. So I think this is a good slide in case you're wanting to take something back to your own centers.
I just had a quick question that probably others have, is how successful have you been in getting this paid for by insurance? It seems like that would be a big barrier. And I also want to give a shout out to the dietitians. I don't know any of it. I've been here 30 years. Any dietitians that ever said, drink as much pop as you want and gummy bears, right? Like, I think we tend to beat ourselves up for the diet that we prescribe. And I think for the most part, people were prescribing high calorie and stuff. So.
No, totally. And the biggest point that I can give to everyone is the diagnosis of CFTR, diabetes on a patient profile that helps you get these medications. I think that you kind of are always playing a game. We do this with modulators, we do this with a lot of different medications, right? Like, you need that diagnosis in order to be if an insurance is not going to cover something. So the biggest success we've had is from making sure we diagnose, we document people's like hemoglobin A1Cs, whatever it might take, or OGTTs, and then we use that as a stepping stone to try to get these GLP medications approved. We've had a couple of patients, I have more slides, but I'm not going to go through all of them, but we've actually had a lot of success with patients that have gained a lot of weight, and this has actually helped with body image issues with our patients.
So, just a quick question. How would you recommend going forward, especially when we get to the next gen registry, being able to also link use of GLP-1s with liver disease, right? So they're thinking about NASH, how to do whatever the term is, and whether this is actually a treatment for that independent of the obesity, right? So we know that it's not being addressed. So how to sort of study that and actually build some literature on that.
I think it's just like the trials that I mentioned earlier. I think tracking that data is the biggest portion, right? Like,
Right, but as liver screenings are, we're going to be doing, like, for example, in all those trials, yearly elastography, seeing the liver disease independently.
I would say yes.
Okay.
I would say yes. I'm a big fan of more screening and more like the data is important, right? Like because of modulators in general, I think we're not doing enough. So I'm in that camp of the more we do, the better we are, but it's not mandated yet, I guess. So maybe we should mandate.
Short. That was a great talk. Thank you so much. I think this is, like aptly placed, a very hot topic. I think there's a lot of ongoing data in, like new GLP-1s in industry studies on lots of comprehensive sort of chronic illnesses, including fatty liver, like definitely happening. And we're seeing it across a bunch of different, like OSA just got and it'd be really awesome if there was a way for that to be updated, like for folks who are in lung disease, like there's a way that we can keep up to date as a group on kind of like what's going on in other diseases that we may be able to use to get the coverage for this for our patients. I don't know what that might look like, but I think it'd be really helpful. And this is just a random thought that came up while you were talking. We had one patient who we did get on this, and we're simultaneously doing an advanced lung disease QI project, and so looking at folks at risk. And so under an FEV1 below 50, and as she lost weight, she actually came out of our advanced lung disease project, which was pretty awesome. So
Yeah, I think the potential is big. We just have to be cognizant of the side effects of the medications, right? Like I think from Utah, so we're a very dry area. Whenever we start these medications, I try to avoid starting them during the summer months, which sounds crazy, right? Because people are outside, they're dehydrated, DOS levels are going to be higher. So I try to actually push to do this during more winter months when they're inside, when they're going to be more adequately hydrated. So that's just like a clinical thing.
I just wanted to touch on a couple of the comments. With the increased incidence of obstructive sleep apnea, I feel like there's not a lot of screening. So if your patient doesn't specifically meet criteria for CFTR, screen them for OSA. As long as they have a BMI over 30 with moderate to severe sleep apnea, then they would qualify for step out for Mounjaro. So just another thought, if they don't meet that criteria and it's something that you want to push for your patients, and they have us.
Totally.
Question. One of the things that we've heard a lot about this week is inflammation. And are you able to talk at all about the impact of GLP-1s, like tirzepatide or semaglutide, their impact on it?
I don't have a bunch of information from that perspective. I think that overall, we talk about from a pancreas standpoint that it decreases the amount of inflammation, so that helps the disease process. But other than that, I don't have much.
It's on tapering. Do you have any guidance on tapering people off these medications once they reach their goal weights?
Yeah, so that's the big question, right? Like, are these chronic medications, and are they going to be on these medications for the rest of their life? And I'm cautious with the way I answer this question because I think they are chronic. I think that once you're on it, it will help you. I've yet to see anybody that we've actually prescribed that we pulled off of the medications. So they've stayed on them, and that's helped them maintain a new baseline. So I would, if anybody has tapered off of any of these GLP-1 medications, I would love to hear about that. Response. They're fairly new, right? So we don't know the long-term implications yet. So I think that it is important, and I think that that's definitely something that we should look into. I've had people ask me that about modulators. They're like, what do we do? Like, are you going to be on this for the rest of your life? And I'm like, I think so, right? Like, I think that that is the path that we went to in order to help with the underlying process of the disease. You kind of need to keep taking it. So I haven't seen anybody be tapered off, but it's a great question.
Have any thoughts on decreased bone mineral density when they go to step and then maybe supplementation? Any adjustments?
I think that it's very important. This is where our dietitians are very important and they're very key because they've stayed on top of making sure that we're doing all of the monitoring that we need to do to make sure that the patients are on. I do think that the type of weight loss that occurs with the GLP medications, I don't think it's necessarily, when I look at the general population, you're losing muscle mass, right? Like, so it's not the best. You're not just losing fat. Like, people think that you're losing weight. Yes, you are, but you're losing good weight in many patient populations. I don't know if that's been used in the cystic fibrosis population. In the general population, I do think that we should be cautious because you're absolutely correct. We are decreasing bone mineral density. We are decreasing the good amount of weight that patients.
So Lucy Gale is a senior research dietitian and project manager, a PhD student at the department, and PhD student in the Department of Medicine at the University of Cambridge. She has over 20 years experience and 12 years cystic fibrosis experience.
Hello everyone, thank you to the organisers and to the committee for the invite to speak. I'm here on behalf of Professor Floto, who unfortunately can't attend today, so I will do my best to explain this. So we do actually have some disclosures. We've been lucky enough to have some CFF funding for some of our studies. So I'm going to talk to you a little bit about home monitoring and the work that we've been doing, and then talk about some practical aspects of that may be a bit in clinics over time. So there's a huge promise for using home monitoring, AI and machine learning in clinics. So obviously our population's changed, there's huge patient change. They don't want to come to clinics. Don't want to be travelling distances, they don't want to be risk of infection. It also helps with stretch CF centres, and we can have predictive innovation, which is what I'm going to focus on this. And then we can also reach physiology. And now we can also use it to safeguard treatment. So this is a quick pipeline of our been home monitoring for 14 years now. So we started off with pilot back in 2011 telemed. That was just in 15 patients. We moved on to a feasibility study called Smart Care CF, and that was across 7 centres. And then we were able to do some implementation. So Project Breathe was the biggest one of those, which finished in 2023. And some patients on that were on it for up to 5 years. And then now we are running a large multi-centre RCT, which will finish early next year. And I'll talk to you some more about that as well. These are all UK, apart from, I'm just going to mention about Project Breathe very briefly, and then talk about Smart Care, and then a little bit about ACE. So Smart Care and Project Breathe, there should be papers published extremely soon for both of those, which we're excited about. So all of the patients in all of these studies are given various bits of home monitoring. So they these handheld spirometers, oxygen size probes, weight scales, and for some of the studies they have temperature to monitor. Also simple activity monitor or watch that monitors their activity, but also things like steps, heart rate. And then they also can be coughing and the score, so that's just very subjective, like a scale, where patients pop down each day how much they're coughing and how well they're doing. So this feeds through to a bespoke app that is developed with a lot of patient input. And we've been relying on it all the time. And also all this data can feed through to the patient portal and can be seen real all the time. So it's in Project Breathe, but also excitingly, we've got a study in Ontario in Canada, which is just to finish next year as well. As it's been great to get to work with those guys. Just a very quick snapshot from Project Breathe, and this is the data that we looked at pre-ETL and pre-COVID. There was a big impact on lung function and the number of days of antibiotics that were required over 6 months, so a reduction of almost 30%. The majority of patients found the app and the tech very easy to use, and there was lots of feedback about how they felt empowered to take control of their own health and the depth of information that it was giving them. So just skipping back a little bit, so Smart Care, we took all the home monitoring kits plus the daily sputum sampling of these patients who were amazing and thriving on this. Absolutely instrumental in this work. So that was in 147 adults. They were on the study for 6 months, so that's produced an awful lot of sputum in that time. So this is just a heat map to give you an idea from the 104 patients that are on the heat map. Now, let me just explain the left-hand diagram. More green is good, so more green is loads of patients are doing, and on the bottom is time. So as we expected, everyone starts off full of enthusiasm, but there will be a little bit of tail off as time. But I think they did an amazing job. And then the right-hand bar chart just shows the number of participants and how many exacerbations they had during that period. So there was around 30% that didn't have any over that 6-month period. And then, as would be expected, those patients had 6 exacerbations. Just to illustrate, normally in conventional clinic, you will get a snapshot of measures. So CRP, you might get an FFP1 if they're able to manage it when we're assessing to start antibiotics. So we're literally just going on a few numbers. Whereas I know this is busy and this is an example of which data that we get with our home monitoring. So from the top, we've got lung function, moving down oxygen sensitivity, temperature, cough, hours, and the pale that's there, like peachy pink bars, that's where patients have had antibiotics. And then further on, you can see where this patient had or can be. So there's a lot to be going on there. I'd much rather, as a clinician, look at this in a snapshot of data. And what we're really interested in is the section I've just highlighted here. Before people know that, before they need antibiotics. And that's what we really focused on as a team. So the very clever people in the machine learning, data scientists have looked at, well, actually, what does a typical exacerbation look like? And we've come up with this curve where people go along quite happily, and then all of their physiological parameters will start to decline until we start with some IVs. Now, normally they might have to wait a little while. I don't know about in the US, but in the UK they may have to wait a little while for a bed. And then how would it be if we could start them? Could we start them here? Could we even start them here? Decline entirely. So as we all know, repeated severe infections to long-term damage. So this is which we're really excited about the results of our model. So these are all the physiological parameters again, and how they change from baseline. So if you see them very stable, the black line means it's showing the day that you started exacerbation. Is predicted. Then there'll be a decline in parameters. And very interestingly, we found a slight uptick in measures before the terminal decline was started. That makes sense. So then we started to think, well, actually, exacerbations are the same. And the answer is no, they're not. We've come up with three main classes of exacerbations, and they all have different types of patients. Now we've just filtered out to make it easier and to be less noise for you to look at, just with lung function and wellness. So lung function is the orangey bar and wellness is the blue. And again, the black line is days from start of antibiotic exacerbation. So class 1 is what we would think as a typical exacerbation. These patients tend to have higher Pseudomonas. Class 2, they have delayed function decline and reduced CRP, so we might not be picking up them in clinic if we're relying on lung function. And then class 3, well patients who have decline. Then how can we predict this? This is 2 examples of participants with their physiological parameters, and with machine learning based on our smart data, we have been able to predict, up to 10 days before they've got symptoms or before permission for patient becoming well, which we're incredibly excited about, with pretty good performance. And the coloured diagram on the right just shows the contribution of various parameters. So the orange bars are often storage, and then how much each of those parameters contribute to the overall prediction. Some of the visual lines don't imagine that if you put cough and wellness together, it gives you an increased prediction value. Whereas we found very interestingly, once we put once we took off even 1 hour, actually it didn't move very much. So there's ongoing work on that. And then to ACE, which is our currently running trial. So this is where patients were randomised 1-to-1 to either go into just seeing home monitoring, as I've explained, or to see home monitoring plus our predictive algorithm, which surfaces on the app as a traffic light. So green means actually you're doing really well, carry on, your measures are good. Amber means things look like they're in a little bit of decline, please just focus a bit on your treatments and see if we can rescue that. And red means we've detected there's a decline, please contact your care team as soon as possible. And patients to try to patients out when they saw this screen, but to really with So underneath all this is a predictive classifier and also a safety classifier. Our main endpoint is quality of life. So on the traffic lights, is that quality of life? And then we're also looking at a myriad of others. So on the left is your physiological parameters, and then on the right it's just to illustrate. So with this particular participant, they'd done a lot of great data, and there wasn't any missing data, as you can see from the top right. But what we need to check is that safe? It's no good us taking in the numbers and then just putting them out to the patient. Is there enough detail? In this case there was, so you'll see the colours that were surfaced to the patient. But in this one, as you can see from the red, there wasn't enough data to safely surface a colour to the patient. So they would have had grey for quite a lot of the time, which means please do some more data when you can. But the rest of the time they either had green or amber. So just wanted you to know that we've got lots of things going on in the background for that. So what we really hope is that instead of conventional care, we can have this algorithm alert so that patients know they're becoming unwell, can make a call to the centre, potentially get assessed and start treatment if required. And we'd like to think that that treatment might be maybe not IVs, maybe they could have orals, maybe we could do something else. But if they do need IVs, we could start it sooner. And then instead of keep having to come back to clinics, they can have virtual clinics, which we do a lot of, and we can see what's going on from home by looking at the data that's being coming through to the portal. Or quite often patients just shove the phone under our noses because they're excited to show us. So this slide is a couple of years old now, but the equipment, I'm sorry, it's not in dollars, can be very cheap relative to the cost saving, and kit begins at about £100 or about $80 and moves upwards depending on how much they want to have, and compared to the potential cost savings and reducing of patient burden and their quality of life, we think is huge. And very quickly, I'm just going to talk to you about our new work that's coming through. As well as this, we want to help to enrich registry data, because wouldn't that be lovely if we could put all of this physiological data alongside what's already in the registry. And we're working on developing new sensors, which there's a poster here and some other work on. So this is one of them. It's a radar device and it blows my mind. It measures heart rate and respiratory rate completely remotely. No wires, no sensors, no attachments, no nothing. It just sits there and does its thing. It's incredible, and it measures every few seconds. Voice biopsies where patients speak into an app. They just do one lot of speech once a day, and we're just working with the company to see if it can detect minute changes in the voice that is undetectable to the human ear. And then we've also been working with the very clever John Rogers at Northwestern, who's now with Cyball, and on their various wearables that started off with neonates so that they weren't connected to lots of different wires, so that they could be cared for and picked up more easily. And now this translates to wearables for adults, which measures everything you need just in one sticky device. So I've just opened a study with that, and I'm looking forward to seeing the results. And then also, obviously, to go back to the sputum samples, we are in an amazing position where we can now, alongside these physiological measures, look at actually what was happening with the sputums, what was happening with their biological markers. Can we discover any new ones? Is there anything new that we can find that might help us with diagnostics? Maybe we could have a bedside diagnostic kit at some point, and nice and quick. Technology is moving fast. And also just for discovery, looking at, can we think, is there new ways to think about infection, what's going on? Can we come up with new tests? So, in summary, we've shown that home monitoring is effective and it detects pulmonary exacerbations earlier than currently, and we're now got the multi-centre RCT underway. We might be able to intervene sooner, and also it can help safely withdraw treatments, and we might get some more biological insights into what's going on. And also we've got to think about cost savings, so that is also very possible. So there's been a huge amount of people that have been involved in this over the years, but really the biggest thanks is to the participants who have been incredible. And that's it. Anyone's got any questions? Thank you.
Hi, my name is Beth Debry. I'm with Coral Health Peds. Really quick question. Any discussion of bringing this work into the Peds space at all?
Yeah, absolutely. It's a great question. I think I would need to ask for advice on all of you guys who work with peds, but we have patients from 16 and up, and I see no reason why younger patients can't do it. They're great at using all this tech. They show me all the time. Yeah.
Pedro Mondejar from Spain. Thank you very, very much for the great presentation. It's so interesting, all your projects. So I think that it's very useful nowadays in people with CF on high efficacy modulator therapy that, sometimes they don't realize that have pulmonary exacerbation because they have other symptoms, not the classical symptoms, not cough or not sputum production, simply bad mood or a minimal decrease in oxygen saturation, high rate frequency or something like that, mainly in very mild lung disease, or on the other side, on very severe lung disease. So I think that this is very interesting for this type of patients. Thank you.
Thank you. Thank you for your comment. Yes, we're very interested in the new presentations of exacerbations and catching patients by unawares because they present so differently to before. So it's been very helpful. Thank you.
So two quick questions. One, it sounds like the randomized controlled trial is going to be basically a push phenomenon, meaning patients will see their scale and then call into the center.
Yes.
Is there a clinician-facing side of this where clinicians will be able to get access to this and decide to pull patients based on their monitoring, so to speak?
Yes, that's a good question. So there is a clinician portal that we can access. However, because this is a research study, we need to wait for the participant to contact us. But the plan would be absolutely, if we could see declines in measures, I'm sure we'll end up having an alert, and then we could contact the patient when it was clinical practice.
It may be interesting just to do a concordance study to see when providers would actually want to pull the patient versus when the patient pushes into the system and see where that lag is.
Absolutely.
And that you should be able to do because you're not actually bringing the patient in, but you're basically just doing it behind. The other question is your machine learning, your phenotype clustering, is that at the patient level or the exacerbation level? Meaning, are patients in multiple different phenotype clusters across their different exacerbations, or do patients cluster into one phenotype predominantly for their exacerbations?
I'm sorry, I don't think I've got the background to answer that. I'm not sure what the team have been doing with that, unless Dr. Howarth at the back can help.
Right, like so is someone always like going to be like a type 1 exacerbation or a type 2, or do they go from type 1 to type 3 type of thing, or whatever I think they're 1, 2, and 3.
I think they tend to stay within the same. Each time they exacerbate, it tends to show the same pattern once they've gone into that group.
Okay.
Sorry, Charlie.
No worries.
Hi, I'm Carissa from UNC. It's absolutely amazing what we can do with so much data. I think one of the other questions comes to mind, some patients who are very wary about data and that being stored. So what aspects in terms of privacy of health information?
Oh, thank you for that. That's a good point. So for this, all of the patients are given an anonymous email account and a link anonymized number for their study that only their study team can unlink. So none of the rest of the team are able to see that. So nothing that's going through into any of the apps can be identified by anybody outside of the research team. And there, we also go through very carefully about confidentiality. Everything meets GDPR rules. But yes, we do have to be very careful, and we take great care of the data, even though it's anonymized.
Good morning. It's Matt Hazen from Emory in Atlanta. Any concern considering how much information you're getting for false positives, where we're overtreating as a result of small spikes that are then misinterpreted?
Absolutely, thank you. Yes, so that is something that will be looked at. As far as I'm aware, there has to be 3 consecutive spikes. So even if they're small, for then the colour to change and to be surfaced, if that helps. So it won't suddenly react on a one-off. But that is all part of the work that the team are doing on the safety of the app and the way it surfaces.
Hi, at this time, Eric Walter from Portland, Oregon. This is amazing. Thank you for presenting. I'm a little bit worried that my voice is being checked right now on the radar in the room that it's a spike. Your patients in the UK are far more compliant than my patients.
Oh.
When I've done home monitoring, oftentimes I call them and ask, what was your spirometry numbers? And they'll say, I don't remember where that is. I moved 6 months ago and I haven't found it. So when you move this out of the research, or in past studies, when you moved it out of the research realm into more day-to-day use, do you see a drop-off in compliance and monitoring?
So we've got a stalwart of patients who have been in home monitoring from the beginning, and they've carried on. But it's hard to know because we've opened to so many new centres. So lots of people joining this study are new, and it's shiny and new, and they like it. What I didn't explain at the beginning, which I really should have done, is everything is linked up via Bluetooth, so nobody needs to enter anything manually. So if they do the measure, it goes to the app and it goes to the clinician portal. I mean, sometimes you get tech blips and you need to resync. I'm not saying it's perfect. But yeah, there is a drop-off over time, as we saw with the heat map. And some patients use the tech more when they're unwell. Some people use it less when they're unwell. Some people find it. One lady said to me the other day, well, I don't feel I can lie to you anymore because I've got the data in front of me. And I was like, okay, well, thank you for being so honest. But it works well for different people. Thanks. Okay, thank you very much.
So I think we're done now for this session. So thanks everyone for coming. And I so appreciate our speakers today. Thank you so much. It was a great